pattern of cells. Now, we explain about apoptosis. Apoptosis or programmed cell death or falling off, because it's similar to falling off in ultra. When apoptosis occurs, apoptosis occurs for elimination of unwanted cell, and then the cell need ATP. In apoptosis is physiologic in many situations rather than necrosis. Necrosis is almost always pathology, but apoptosis in many situations, no all situations. In many situations, apoptosis is physiology and necessary in our body. Okay? So, in apoptosis, we have degraded cell and nuclear material. Ultimately, we have apoptotic body. And apoptotic body recognized by host phagocyte without any exaggerated inflammation. With necrosis, we have exaggerated inflammation. Or body or tissue damage from necrosis and exaggerated secondary inflammation. But in apoptosis, recognized by host phagocyte without inflammation, and elimination of tissue is done with minimal damage to the tissue. Okay. This figure shows some example of physiologic apoptosis. For example, in embryogenesis. Okay. If the apoptosis is not in embryogeny, all of you might have tail and other abnormal organs. Okay. But in physiologic apoptosis in embryogenesis, cell development and configuration of limb and some internal organ is altered. And also, in physiologic apoptosis, we remove the cell after done the purpose and the activity. For example, when we have inflammation, we have neutrophil, lymphocyte, macrophage in the blood increase. But after removal of inflammation, we don't need these cells. So this cell, without any damage to other tissue, removed by apoptosis. And also self-reactive cells in our body, for example, in tumors, in bone marrow, due to the development of lymphocytes, removed when recognized autoantigen. Also, apoptosis deleted some offset. For example, in hepatitis B, we have infected liver cell with HPV and lymphocyte in HIV. The apoptosis removed this infected cell, remove the cell involved by cancer cell, or in some situation, transplanted cell. So apoptosis physiologic situation is necessary. Also, the other example of physiologic apoptosis are hormonal. MEMS is apoptosis after decrease in estrogen and progesterone in the female. We have release of endometrial tissue and MEMS is occurring. Also menopause is physiologic apoptosis. Also prostatic atrophy also is physiologic apoptosis. And some organ, for example, is the intestine. We have many removal of old cell replaced with new cell. Is done by apoptosis. This is example of embryogenesis apoptosis, intestinal and replacement with new cell, and new cell replace older cell, older inflammatory cell in the development. But also, we have some situations with pathology of apoptosis. For example, after radiation, after treatment with chemotherapy agent, anti-cancer drug, after excess heat, we have increased mitochondrial permeability and apoptosis with pathologic situation. In this situation, we have a disease, we have a loss of cell, and ultimately, this is due to deletion of some needed cell. This table explains the most common physiology and pathology of apoptosis. Physiology during embryogenesis, turnover of proliferated tissue, we explain, for example, intestine, and hormone-dependent tissue, involution, for example, endometrium, elimination of potentially harmful self-reactive cells. But pathology, when we have DNA damage, accumulation of misfolded protein, we discussed the last session, and infection, especially viral infection. HPV, HCV, HIV has deletion of cell with apoptosis, and this is occurred due to deletion of normal cell after infection and apoptosis. So, what's morphologic changes in the apoptosis? We discussed about necrosis. In necrosis, we have irreversible damage to three major intracellular organ. What is organ? What organ? Damage in the necrosis and in favor of irreversibility. DNA, mitochondria, and cellular. Okay? Three organ damage. But in apoptosis is different. In apoptosis, we have shrinkage of the cell. But in necrosis, we have enlargement of cell due to cell swelling. Also, in apoptosis, we have condensation of nuclear material, fragmentation of nuclear material, and ultimately, apoptotic body. Apoptotic body contains cytoplasmic organelle. Apoptotic body recognized by tissue phagocy and removed without any aggregation of inflammatory cell. So, in apoptosis rather than necrosis, we don't have increased permeability in the cytoplasmic membrane and organelle membrane. We don't have inflammation. We have decrease in size of cell. And these are the morphologic changes and intrastructural changes is different rather than necrosis. But what is mechanisms of apoptosis? We have two common pathways for apoptosis. Mitochondrial pathway, intrinsic, and extrinsic or cell receptor pathway or this receptor pathway. In mitochondrial pathway, when we have mitochondrial pathway is a main pathway for apoptosis. In growth factor withdrawal, absence of survival signal, protein misfolding, DNA damage due to toxin, due to free radical, due to radiation, we have activation of BH3 family protein. BH3 family have two types of protein, back and back, in favor of apoptosis, BCL2 and BCL-XL anti-apoptotic factor. So, when we have situation that apoptosis started, BCL2 family such as BACs and BAC activated. BAC and BACs affect mitochondria mitochondria and increased permeability in mitochondrial channel and associated with exit of some protein such as cytochrome C from mitochondria. Cytochrome C activated caspase, cysteine aspartate enzyme. In phosphate ligand or this receptor, we have attached fast ligand to fast, and this domain activated. In situation, also caspase 8 is activated. In mitochondrial pathway, caspase 9. In this receptor, caspase 8 is initial caspase to starting of apoptosis. So other enzyme is activated, nuclear fragmentation, and apoptotic body is produced, and apoptotic body by some signal in the surface recognized by tissue phagocyte and removed. Ultimately, apoptotic body is produced and removed without any inflammation. So we have pro-apoptotic protein and anti-apoptotic protein, all of BH3 family, pro-apoptotic back and bags, anti-apoptotic BCL2 and BCL6. In this figure, we have regulatory of anti-apoptotic such as BCL2 and BCL-XL in this figure. In the tissue, for example, this figure lymphoma, proliferation of neoplastic lymphocyte. We have apoptotic body in the macrophage. Okay. Also in histology, you see in the lymph node germinal center many apoptotic body. Then we have remove of this autoreactive lymphocyte or lymphocyte has no data. Okay, but we have some pathway of cell death. Is not pure necrosis, is not pure apoptosis. For example, necroptosis. Necroptosis is both necrosis and apoptosis. Then we have TNF receptor activation and some kinases called receptor interacting protein or IP kinase is abbreviation. And also pyroptosis. Pyro is fever, apoptosis with fever due to some cytokine, such as interleukin-1, activation of cytosolic danger-sensing protein complex, inflammation. Apoptosis and inflammation coexist. Inflammation is not characteristic pattern of apoptosis, but in some situation, cell death is apoptosis, but inflammation is coexist. It's called pyroptosis. And pyroptosis dependent on the level of cellular iron. This figure shows necroptosis. For example, after chemotherapy of cancerous cell, we have apoptosis cell. Okay? And apoptosis and some cancerous cell resistance after chemotherapy. This cell, after some drug, became necroptosis. Apoptosis and necrosis pattern coexist. And pyroptosis, then we have pore formation. In apoptotic cell, we have intact cytoplasmic membrane. Damage to cytoplasmic membrane is seen in necrosis. While in pyroptosis, we have damage and inflammatory processes occur, and we have fever with apoptosis associated with accumulation of inflammatory cells. And what is autophagia? Autophagia or self-eating. When the cell is very, very hungry, for example, nutrient depletion. We have sensor in cytoplasms, and sensor in cytoplasm activated autophagic gene in DNA level. Autophagic gene affect in intracellular organelle and formation phagosome. Phagosome, formation of the vacuole, contain cytoplasmic organelle. Maturation of autophagosome and attached to lysosome with many enzymes, degradation of intracytoplasmic organelle in the phagosome, and became nutrient material for the cell. It's called autophagy. Autophagy is seen in atrophic situation. Okay. The first, we discussed about hemostasis. They ask you define hemostasis. A healthy cell has hemostatic states, but when we define hemostasis, ability to an organism to maintain its internal environment constant despite change to internal and external environment. It's defined hemostasis. Because we have constantly have alteration in the structure, in the function of cell. But cell have a mechanism tend to maintain an intracellular situation in constant position. It's called normal hemostasis. When we have normal physiologic demand, we have homeostasis. But when we have severe physiologic demand or pathologic stimulus, we have the first adaptation. If adaptation is not possible, cell injury is occurred. After adaptation, reversible injury. After reversible injury is point of no return, and reversible injury is occurred. This figure shows all of cellular response to injurious agent. For example, stress increased demand, we have adaptation, inability to adapt, cell injury. Cell injury is reversible, and in point of irreversibility, we have necrosis and apoptosis or sepsis. Okay. This figure also adaptation, reversible, irreversible injury, and sepsis. It's an example for adaptation. We have some pattern of adaptation. This figure shows adaptation figure. For example, this cell is normal. After a small in size, we have atrophy. Increase in size, we have hypertrophy. Increase in number, we have hyperplasia, and change in phenotype, we have metaplasia. Atrophia, hypertrophia, and hyperplasia can be physiologic and some situation pathology. But metaplasia almost always is pathology. Okay? When we have adaptation, it's reversible change in the cell, in number, in size, and in phenotype. And physiologic situation, we have adaptive response in the cell and organ. For example, in pregnancy, it's need to large size of uterus, okay? Or breastfeeding, it's need to large size of breast, proliferation of number of cell and size of cell. It's physiology. But in some stress agent, we have pathology adaptation. Okay, we discuss. The first, we discuss about hypertrophia. Hypertrophia is increase in size of cells. Okay? When hypertrophia is occur, when the cell cannot divide it, cannot increase in number of cells. We have increase in cytoplasmic organelle and we have hypertrophia, increase in the size of cell. So we have hypertrophia in skeletal muscle and cardiac muscle. We have hypertrophia in other cells, but in skeletal muscle and striated muscle, we have only increased size of cell, no number of cells. So when we have increased functional demand, for example, during exercise and growth factor or hormonal stimulation, for example, in pregnancy, size of organ is increased. Also, contractility, for example, in the striated muscle is increased, and ability to meet demand. For example, in bodybuilding trainers are a good example of striated muscle hypertrophy. We discussed adaptation phenomena can be physiologic or pathologic. Physiologic hypertrophia, uterus during pregnancy became mainly enlarged for embryo due to estrogenic stimulation, breast during lactation, during prolactin and estrogen. But physiology, they have hypertension. The cardiac muscle became hypertrophy. In aortic valve stenosis, cardiac muscle became hypertrophy. It is pathology. We have many mechanisms for hypertrophy. In some situations, mechanical trigger, storage, for example, in hypertension, in valve stenosis, or trophic trigger, for example, adrenergic stimulation or hormonal stimulation. In some situations, we have head and signal transduction pathway, induction of new gene and number of gene, and synthesis of new ones, intracellular organelle, and enlarge of size of cells. Mechanical storage, agonist, and growth factor. There is intracellular signal transduction, transcription factor, for example, MARS, FOS, YUN, and other gene activated, synthesis of contractile protein increase, production of growth factor, and more stimulant, and also induction of embryonic gene. For example, in cardiac muscle, we have embryogenic mucin for better contraction and less energy consumption. For example, it's normal heart, okay, without any stimulus. After hypertension or after valve stenosis, we have hypertrophy in the heart. Can be right side, can be left side. In right side, men we have lung disease. The cell became hypertrophied and organ became larger and thicker. This figure also normal mucin, normal cardiac wall thickness. Normal cardiac wall thickness is 1 to 1.5 centimeter. After hypertrophy, we have enlargement of cardiac muscle and thickening more than 2 centimeters and narrowing of the lumen and essence. Also, after a time, adaptive response became necrotic, reversible injury, and ultimately irreversible injury is occurred, and we have necrosis in the cardiac muscle. For example, in the hypertrophia, we have some situation during muscle hypertrophia, alpha-myosin heavy chain is replaced by meta-myosin heavy chain. Alpha-myosin is slower, but economically is in favor of saving energy and contract. The last adaptive response is hyperplasia. Hyperplasia's increase in number of cells. Okay? After increase in number of cells, the organ became larger. For example, it's adrenal. This figure is normal adrenal. And hypertrophy and most hyperplasia will increase in size of adrenal. It's called adrenal hyperplasia. Hyperplasia is seen in cell with synthesizing DNA and ability to mitotic division. So all of cell except cellulated muscle and brain can be increased in number due to dividing cells. In some tissue, hypertrophy and hyperplasia occur together and have similar stimulus. When we have increase in workload, physiology status, we have increased rate of cell division. Cell number is increased, tissue size is increased, functionality is increased. Hyperplasia also is physiologic or pathology. Physiologic is hormonal hyperplasia and compensatory hyperplasia. Hormonal, for example, in uterus, in the breast, when with female meat, and compensatory in solid organ, for example, in liver after damage, after surgery. We have increased size of, increased number of cells in the liver. We discuss about later. For example, in the liver, we have some stem cell, quiescent cell in the liver. After damage of liver is activated and regenerate liver tissue. Also, we have hormonal hyperplasia. Hormonal hyperplasia, for example, physiologic hormonal hyperplasia occur in the breast after puberty. Before puberty, we have unique ductal structure in breast. After estrogenic stimulus, we have many lobule proliferated of lobular cell prepared for lactation. Also, in pregnancy, we have increase in number and increase of size of cells. And late pregnancy, we have increase in the size of uterus. In the uterus, we have hyperplasia, increase in size, and hypertrophy together. When hormonal or growth stimulus is removed, hyperplasia is this appear. What is mechanisms of hyperplasia? Increase local production of growth factor. Increase level of growth factor response in the tissue. And activation of many intracellular organs causes increase in the size and number of cells. result in the hyperplasia is cellular proliferation. What is pathologic hyperplasia? When we have excess hormone, when you don't need this hormone. For example, when we have excess hormone, excess estrogen after menopause, we have endometrial hyperplasia. It's dangerous and pathology because endometrial hyperplasia can convert to endometrial carcinoma. And also, when I have prostatic hyperplasia associated with some damage and problem in the urination and stopping urination, and activation of some growth factor, for example, after viral infection, for example, skin, wart, endometrial hyperplasia is an example, a good example of pathologic hyperplasia when we have many estrogen rather than progesterone imbalance between estrogen and progesterone. We have proliferated endometrial tissue and endometrial hyperplasia susceptible override by endometrial carcinoma, unfortunately, if untreated. Also, we have hyperplasia in the breast, normal breast, lateral hyperplasia. We have dilatation in normal physiologic state and in some tumoral state in the breast. Also, we have hyperplasia in the prostate. We have glandular and stromal hyperplasia due to hormonal effect. And prostatic nodular hyperplasia is other. And skin wart is an example of cellular proliferation after HPV infection. In this figure, blue particle are HPV virus. HPV virus enter to cell, integrate nuclear material with the nucleus of normal cell, and proliferated cell is occur. Proliferated cell became more and more, and ultimately the wart is occur due to proliferation of the cell. Pathologic hyperplasia, as I tell you, is a fertile soil and susceptible to cancerous proliferation if untreated. But what is atrophy? Shrinkage in the size of cell by loss of cell substance, a form of adaptive response. And in some situation, before cell death, we have atrophy. When workload is decreased in disease state, size of organelle is decreased, energy use is decreased, functionality in disease state also decreased. Atrophy is physiology and pathology. Physiology atrophy during early development due to embryogenesis. For example, notochord atrophia and thyroglossal duct atrophia is an example of physiologic atrophy. Physiologic atrophy also is seen after pregnancy and causes decreased size in the uterus. What is cause of physiologic atrophy? Decreased workload, for example, atrophy of discus, loss of innervation. When we have loss of nerve in the tissue, we have group atrophy, denervation atrophy, diminished blood supply. Is not enough for necrosis, but atrophies occur. Inadequate nutrition, weight loss, loss of endocrine stimulation, aging, senile atrophy, and pressure atrophy. This is decreased workload, atrophy of use. You have experienced immobilization of the leg when it's in a pastel cast. After removal of cast, we have atrophic organ rather than other organ, and it's reversible. Also, when we have denervation, we have more atrophy in the striated muscle. Also, diminished blood supply in the brain in elderly patients after atherosclerosis. We have decrease in size of brain. It's a pathology atrophy. And also, when we have loss of blood flow in the organ, the kidney rather than other kidney is atrophic. Inadequate nutrition, for example, marasmus or chronic inflammatory disease associated with severe weight loss due to inadequate nutrition, and also aging or senile atrophy, cell loss, for example, in brain, in the heart, and other organ in the aging is prominent. And pressure atrophy due to tumoral lesion. When we have tumoral lesion in the organ, has pressure to other organ. This pressure causes atrophy due to abnormal vascularization and blood supply in the normal tissue. Mechanisms: decrease in protein synthesis, increase in protein degradation. We have proteolytic system, activation of some enzyme, for example, lysosome autophagy and ubiquitin proteasome pathway associated with atrophy. We have lysosome and ubiquitin. In nutritional deficiency, disuse, in cachexia associated with some cancer, we have an activation of ubiquitin. Ubiquitin degrades protein, and degradation of protein and intracellular organelle associated with atrophy. Are you agree with 10 minutes break?
Okay.
Yes?